So in the second part of lecture series, we are going to talk about esophageal pathologies. We are going to mainly talk about esophageal neoplasms in this video, mainly pertaining to malignant causes. And majority of these patients present with dysphagia. So esophageal neoplasms, are they important? Well, majority of the esophageal neoplasms are malignant with usually poor prognosis. So it is imperative that we recognize and diagnose this condition as early as possible. So why does it have such poor prognosis? Well, mainly due to the fact that there is presence of rich submucosal lymphatics which favors early metastasis, and there is lack of serosal layer in the esophagus which favors early dissemination. So basically we divide the esophageal neoplasms based on their origin. That is, it is coming from the epithelium or not. Epithelial origin esophageal neoplasms are much more common than in all epithelial ones, and epithelial origin esophageal neoplasms are malignant, usually. The epithelial ones includes the squamous cell carcinoma and its variants, adenocarcinoma, mixed variety of squamous cell carcinoma, adenocarcinoma, and other rare neoplasms. So first let's talk about the epithelial origin neoplasms. So how does the patient present? Well, dysphagia is the most common symptom. Initially to solid food, later it involves both solids and liquids. Patient may also present with pain during swallowing, unintentional weight loss. Patient may also have features of esophagitis and GERD, like hoarseness of voice due to involvement of the recurrent laryngeal nerve, and chronic cough mainly due to aspiration. So what are the risk factors responsible for development of esophageal neoplasms? The risk factors mainly include the alcohol and tobacco, especially for the squamous cell carcinoma. Squamous cell carcinoma is much more common than the adenocarcinoma. However, there is recently change in trend, mainly due to increase in conditions like obesity and GERD. The incidence of adenocarcinoma is gradually increasing. In fact, in certain Western populations, there is equal incidence of adenocarcinoma and squamous cell carcinoma of the esophagus. Even medical conditions like celiac disease, Plummer-Vinson syndrome, and GERD are also responsible. Pre-malignant esophageal pathologies like achalasia, caustic esophageal injuries, and even infectious causes like certain strains of human papillomavirus are linked with the risk of esophageal cancers. There is geographic implication as well, where a population of certain Asian populations and parts of Africa show increased risk. So this is a table summarizing the differences between squamous cell carcinoma on the left side and adenocarcinoma on the right side. You can pause it and have a look at it. So for localizing the tumor, we can divide the esophagus into cervical esophagus and thoracic esophagus. The thoracic can further be subdivided into upper, middle, and lower thoracic esophagus. So basically, from the cricopharyngeus, that is at the level of the upper esophageal sphincter, usually at level of C6 vertebra, till the sternal notch, it is the cervical esophagus. From the sternal notch till the azygous arch, it is the upper thoracic part of the esophagus. And from the azygous arch till the inferior pulmonary vein is the middle thoracic esophagus. And the esophagus which is present inferiorly, caudally to the inferior pulmonary vein, till the gastroesophageal junction is the lower thoracic esophagus. So we have an important classification called as the Sievert's classification of gastroesophageal junctional carcinomas. It mainly classifies the tumors involved in the gastroesophageal junction according to the relationship between the epicenter of the tumor and the GEJ. So it is divided into three types: type 1, type 2, type 3. Type 1 mainly includes the carcinomas involving the distal esophagus, where the epicenter of the lesion is 1 centimeter above the junction till 5 centimeters above the junction. Type 2 mainly includes the carcinomas where the epicenter of the lesion is 1 centimeter above and 2 centimeters below the junction. And type 3 includes subcardial variety where the epicenter is present present 2 centimeters beneath till 5 centimeters beneath the gastroesophageal junction. So basically in these three types, type 2 is the main gastroesophageal junctional carcinoma. Type 1 is mainly treated as esophageal cancer, and type 3 is mainly treated as gastric cancer. So to diagnose Esophageal neoplasms, what imaging modalities can we use? We have endoscopic ultrasound. Endoscopic ultrasound is highly effective for assessing tumor depth, for T staging, and also for local lymph node involvement. We have CT, which is useful for staging, particularly for assessing distant metastasis and also local adjacent structures. PET scan provides metabolic information about the tumor and can detect distant metastasis. MRI, though not commonly used for esophageal neoplasms, owing to its better soft tissue delineation, it can be used to evaluate the extent of local invasion. Then we also have barium swallows, which helps in initial assessment of the esophageal structure and function of it. So, why imaging is important? What are the objectives of imaging in esophageal cancer? Mainly to detect the presence of tumor and further do biopsy from it for diagnosing it, and also to identify the epicenter of the tumor and extent of it both proximally and distally, to check the invasion of other adjacent structures like nodes, and check for monitor response to therapy. Well, staging is of utmost importance as the treatment of the esophageal neoplasm depends on it. So to understand the TNM staging easily, we have to have a basic idea of the layers of esophagus. So esophagus has four layers as depicted in the image on the left hand side. The innermost layer is the mucosa, which is further subdivided into inner lamina propria and outer muscularis mucosa. The second layer from inside is the submucosa, where mycinous plexus is more commonly present in this layer, which is responsible for production of secretions. The third layer is the muscularis layer called as muscularis propria, which should not be confused with muscularis mucosa of the first layer. And in this third layer, muscularis mucosa, there is Auerbach or myoenteric plexus, which is involved in development of achalasia cardia. The fourth layer is the adventitial layer. As already discussed, there is absence of serosal layer in the esophagus. Instead, there is presence of adventitial layer, and absence of the serosal layer contributes to the early dissemination of cancer. The same can be depicted in the endoscopic ultrasound image. The innermost layer, which is appearing hyperechoic, which is shown by the pointer, is the mucosa. The layer adjacent to it, the hypoechoic one, is the submucosa. The layer adjacent to it, the hyperechoic one, the third layer is the muscularis propria, and the last one is the adventitia. So why is it important? Well, this is the simplified version of T staging of esophagus that I have made. So this is the lumen of the esophagus, and from inside to outside we have the mucosa, submucosa, muscularis propria, adventitia, outside which there are adjacent structures like aorta, etc. So mucosa, as we already discussed, is divided into lamina propria and muscularis mucosa. So whenever there is a tumor of the esophagus involving the mucosa and submucosal layer only, then it belongs to T1 stage. If there is invasion into to adjacent muscularis layer also, then it becomes the T2 stage. If there is involvement of the adventitial layer, then it is the T3 layer. Involvement of any other structure is T4, and if it is resectable, then it belongs to T4A. Resectable meaning there is involvement of pleura or pericardium or diaphragm. Anything other than this, if it is involved, it becomes the comes under the unresectable, non-resectable criteria, which is T4B. T1 is further divided into T1A and T1B, basically based on the involvement of mucosa or submucosa, respectively. So this was a simplified version of T staging of esophagus. The same is that the whole TNM staging is depicted in this image. A T we have already discussed, and the N state is the nodal involvement is further divided into N0 to N3 status as shown. Metastasis is divided into M0 and M1 based on the absence or presence of metastasis respectively. Histologically, it can also be divided into G1, G2, G3, G4 from well differentiated to undifferentiated variety respectively, in that order. So how do we approach this case? So we have a patient who is 67-year-old male who has with long-standing history of alcohol and tobacco intake, who is complaining of dysphagia mainly to solids since 2 months and with incidental weight loss of 20 kgs. So The descriptors in this case are the age. It's an older age patient with history of alcohol and tobacco, dysphagia to solids, indicating that there is a mechanical cause, and short duration of symptoms with unintended weight loss. So in this patient, the history most likely is going towards the malignant cause. So in this patient, first we have to perform endoscopy as we are suspecting a mechanical cause for obstruction to look for any lesion. And if the lesion is present, we can do biopsy for definitive diagnosis. So in this upper GI endoscopy, in this image, we can see the lumen of the lower esophagus over here, where we can see intraluminal nodular mass, which is causing obstruction, which is causing significant luminal narrowing of the esophagus with upstream pooling of contrast. And from this lesion, biopsy was taken. After which, barium swallow was performed. And in this barium swallow, we can see the diaphragmatic border, rugal folds of stomach, and in the distal thoracic esophagus, we see a intraluminal filling defect due to a polypoidal mass which has a lobulated margin and it's causing significant luminal narrowing. However, still there is distal passage of contrast, indicating that there is some partial obstruction. So the biopsy which was performed, the result turned out to be a squamous cell carcinoma of esophagus. Now, the role of CT is to mainly stage the tumor. The role of CT is mainly to check for local involvement, local adjacent structure involvement. The main T staging is mainly done by using endoscopic ultrasound, which is the investigation of choice for T staging, as we already talked about. So in this endoscopic ultrasound images of the lower esophagus, we see a irregular, ill-defined hypoechoic mass in the distal esophagus, which is invading the muscularis. So in this image, the layers are not delineated properly, but we can see a hyperechoic layer over here, which is probably the muscularis propria layer. And clearly the tumor has invaded the muscularis layer. So it is T2 or above. There is involvement of the adventitia as well. So it definitely at least is a T3 tumor. Now, whether there is T4 or not, we have to check for adjacent structure involvement, which is better depicted on CT. So CECT was also performed. The essential point we have to remember is that we cannot differentiate between layers of esophagus on CT. So we cannot differentiate between T1, T2, and T3 stage on CT scan. The main use of CT is to check for adjacent structure involvement. That is, if the tumor is belonging to T4 stage or not. So in this axial contrast enhanced CT section, at the level of the distal esophagus, there is circumferential thickening involving the lower part of the esophagus with significant luminal narrowing. However, there is maintained fat planes with the adjacent structures, the adjacent pericardium, the triangular fat pad between the aorta is maintained. There is also additionally there is mild right-sided pleural effusion and ascites. So in this FTG PET scan, it demonstrates high uptake, which is corresponding to the area of abnormal thickening at the distal esophagus. So what are the other malignant neoplasms of esophagus? We have a spindle cell cancer, which is a variant of squamous cell carcinoma. It has both squamous and sarcomatous component. It is a variant of squamous cell carcinoma, which shows sarcomatous metaplasia. It is classically seen in middle to elderly age group. It is quite rare with incidence up to 2%. Imaging wise, it is not at all possible to differentiate squamous cell carcinoma from spindle cell cancer. And the only way to diagnose it is biopsy. So another cause of malignant esophageal neoplasm is the lymphoma, primary lymphoma esophagus, which is rare, classically seen in immunocompromised patients with HIV as a risk factor, and it also shows completely non-specific features. So diagnosis on imaging is difficult to do. Diagnosis obviously is finally made on biopsy. And the other entity is the primary malignant melanoma. It is even more rare with incidence of less than 0.1%, seen in elderly age group, classically involving the middle third of the esophagus. and diagnosis based on biopsy. The features of CT and endoscopic ultrasound are highly non-specific. However, MR can be highly useful in this case due to the presence of T1 hyperintensity mass seen in the esophagus, suggesting the possibility of melanoma. Thank you.